Okay, we're back. So we've been talking about what is the significance of what COVID-19 taught us. When I'm talking about us, I'm talking about the population in the world globally, because all this research is now coming back from all these different countries that are actually spelling a kind of a different picture than we've ever heard before about how we can protect ourselves, how they can protect their population. And it's been a phenomenal change. And I talked about that last time. You know, all those people that had the worst cases, and what is it they have in common? Those with long COVID, those with long haul COVID, those who died from COVID, what do they have in common? And it's a number of things, and I'm going to go deep into the details and come back up with some surface answers that you can use for yourselves. But remember, this is not one size fits all. I got to repeat that. This is not one size fits all. We all need to do these things. I'm going to come to a few recommendations that are probably applicable to most of us. But there's still bioindividuation that makes a difference from one person to the other. We can't all do the same thing and get the same outcome. That doesn't work that way. All right, so from the previous video, we saw that the age group most affected by COVID, the flu, etc., are those over the age of 50. We talked about that specifically. Suddenly, after 50, the mortality, the number of people who died from COVID, we're speaking about the United States statistics, that died from COVID jumped up. So under age 50, only 6% of all deaths of the whole population. And suddenly, 93, almost 94% of everybody after age 50. And it wasn't just like, well, of course, you get older, you get more sensitive, you get more vulnerable. Yeah, that's sort of such a generalization. It's not very helpful. Why is it that something happened so precipitously after age 50 that compromises our immune system? Wouldn't you like to know that? That's what we're talking about today. So COVID, to review briefly, we talked about all viral respiratory infections come in through the ACE2 inhibitor. We've heard a lot about ACE2 inhibitor, and this should be called ACE1, but it's just an ACE inhibitor. ACE inhibitors have always been used in medicine for people with hypertension. So an ACE receptor on our cells, primarily lung cells, which is our nose, throat, lungs, and then the rest of the body as well. I went into that the last video. They are pro-inflammatory. They constrict, they make your blood pressure go up, they make for a lot of free radicals. They are trying to fight something. But when that is the dominant mode all the time, hypertension and pro-inflammation happens. And how can you turn that off? Well, that's how viral infections start. They basically disable the ACE2 inhibitor, which is just the opposite. It vasodilates, it opens things up, it lets you breathe, and it's an anti-inflammatory. So they disable that, they come in through that receptor into the cell, and then they self-replicate within the cell. But that is the entrance. That is the front door. So it's all about the ratio between ACE and ACE2 receptors. And when we're pro-infection and we're just sort of all the people that had those long COVID, and who died, they find even in autopsies that they had pretty much all ACE receptors open and functioning, and the ACE2 were dysfunctional. So it's the ratio they looked at, a lot of one and none of the other. The three things we learned from COVID that changes what we can do to protect ourselves against the next flu season, like never before. This is information that came out of what we're learning about COVID. So it's this, as I said, tsunami of all this information. It changes things. So for every subsequent flu season, what is going to be a respiratory viral infection? That's what flu seasons are, respiratory viral infections of whatever type. And there's different families that have always been out there. There's always been a coronavirus. And I'm not going into the specifics of the viruses. I'm saying we experience in humanity, winter after winter after winter, a flu season. We now can protect ourselves unlike anything we've ever been able to do before. What we know and what has been discovered from the data collected through the pandemic so far. Endogenous deficiency of glutathione as the most likely cause of serious manifestations and death in COVID. That's the name of a study we're going to go into. Glutathione deficiency limits the effectiveness of vitamin D, meaning it's a higher priority. The risk of severe COVID can be stratified by omega-3. You know, I've showed you all different labs before. You measure your omega-3. Those are the lowest, are most prone to have very bad experience, if not death. And these are things we can take care of. That's why I put them here. So the endogenous deficiencies of glutathione as the most likely cause of serious manifestations and death in COVID-19 patients. And so this is actually the title of the study. The first of many studies that focused on the nutrient deficiencies of the individual in addition to the virus that affected them. They didn't just go, Oh, we have Omicron. Oh, we have SARS-CoV-2. Oh, we have RSV. That's important. But what about the individuals that suffered or died? What about them? What did they have in common? This is what we're looking for now. So these studies that happened because of COVID, suddenly they had all this data and go, this is what our data is telling us. Whether you're in Oman, Iraq, Argentina, Chile, Mexico, United States, China, Japan, on it goes. Thailand, all this data is coming in from what they saw, which makes it so valuable. This Russian study turned the COVID world on its head. I mean, it came out with saying, I think it's about this. Can you imagine that? You think it's about one thing? Oh my gosh. So that spawned all these other research. I'm just going to give you a couple titles. Glutathione deficiency in COVID illness. Does supplementation help? That's the question to ask. Why was it asked in the United States, huh? What about glutathione supplementation as an adjunctive therapy in COVID-19? Oh, an American one. What do you know? This goes on. Glutathione supplementation appears safe and could possibly be helpful, estimating glutathione is not done routinely. In other words, taking to the lab is not done routinely. Therefore, clinicians should identify patients at risk for glutathione deficiency. They should identify patients at risk for glutathione deficiency. See how these are coupling together? All right, another one. Glutathione deficiency in the pathogenesis, the disease of SARS-CoV-2 infection and its effect upon the host immune response in severe COVID-19 diseases 2022. That's American. I bet 2 years after this one. GSH is reduced glutathione. Depletion may have a fundamental role in COVID-19. Therapies enhancing reduced glutathione, GSH, could become a cornerstone to reducing severity and fatal outcomes of COVID-19 disease, and increasing GSH levels may help prevent and subdue the disease. Back to this one, the American one, says, wondering about supplementation for glutathione, says, based on the evidence showing that reduced glutathione inhibits viral replication, decreases, we know this from documentation, decreases levels of IL-6, that's an inflammatory marker in HIV and in tuberculosis patients, and benefits pulmonary diseases process. It benefits your lungs. They're saying, hey, that's just logical. Maybe we should try this. Huh? You think? Conclusions. We believe that the use of liposomal glutathione could be beneficial in COVID-19 patients. And there's a number of clinical studies being done on this. This is profound. They didn't think of this before COVID. It was because of COVID. It's like, we need something simple that everybody can do to drop the numbers. It's too much taxing on the hospitals, on the health plans, etc. Glutathione, NAC, which they're both pretty similar. This is a precursor for that one. All right, glutathione. The role of glutathione in protecting against severe inflammatory response triggered by COVID-19. That's an Italian study, 2020. The key to fighting this harmful inflammatory response resides in addressing the mechanism of the virus penetration into the cell by binding to and inactivating the ACE2 protein receptor. So the virus goes in through that receptor, locks the door, if you will, and contrasting the exacerbations of the inflammatory response. So it's all around the ACE2, and we'll get to it. Drugs that decrease glutathione levels are acetaminophen, Tylenol, best known for that. Even the World Health Organization has acknowledged that. That goes way back into the 60s. Adriamycin, which is a antibiotic. Antimalarial drugs, for sure. Quinine, quinones, chloroquine, which is a malaria drug. Opiates, ethanol, antidepressants, most commonly prescribed medications in the US, deplete, reduce, prevent the production of glutathione. That's a problem. It contributes to further depression, etc., etc. Conditions associated with low glutathione, lung infections, HIV, diabetes, cancer, and age-related diseases, severe COVID-19 disease. Now, under NAC research, N-acetylcysteine for prevention and treatment of COVID-19, evidence and future directions. Another Italian, look at Italians are right on it. Another Italian study, NAC given as IV to COVID patients. And here's their strategy going down. First, they start with oral. So for COVID-19 development, and this is their NAC strategy, first they're exposed, oral NAC, 600 milligrams twice a day. That's pretty normal recommendation. And then it goes, well, as things develop, fever and cough, increase the oral to 1,200 milligrams twice a day. That's heartburn. I don't know about you. You take too much. The thing about NAC, it is a precursor for glutathione, but it's very hard for the stomach to break it down. So it's a real burden, and people get often really severe heartburn, which is stomach acid and so on. So that's a tough dose. I understand the logic, but it's rather tough. And when it gets worse, then they switch over to IV. So now they're in the hospital and they're getting IV, and even worse, they're getting more IV. So that makes sense, and I'm glad they're doing it. So the last one, this is pollen. So reactive sulfur compounds, which are both glutathione and NAC, and one more coming. SARS-CoV-2 is an RNA virus, yes, we knew that can cause acute respiratory failure and thrombosis, that's clots, and heart attacks, and permanent damage to the heart muscle during and after the infection. So due to their documentation, anti-inflammatory, antioxidant, antiviral effects, reactive sulfur compounds, lipoic acid, otherwise known as alpha lipoic acid, which is a sulfur compound, NAC, you know about that one, glutathione, you know about that one, have inspired further research for the treatment and prevention of diseases caused by SARS-CoV-2. Enter glutathione. Why this time it can be dramatically different. I'm not kidding you. You know, this is all these people, think about all these people have died in these various countries that have sophisticated medical labs and procedures, and yet they couldn't help them. The vaccine wasn't helping them. But it's more about they were nutrient deficient, and why was that? Briefly, what I told you before, why glutathione deficiency is a problem. Glutathione deficiency is a problem because it does just the opposite of the virus. It increases the ACE2 receptors, makes them open, so vasodilation, so they can breathe. It's antiviral, right? Antiviral is over here, is the SARS-CoV-2 does just the opposite. So this is an antioxidant. It reduces reactive oxygen species, the dominant inflammatory pathways, which is what this actually creates. It decreases the exacerbated inflammation. So that's from the role of glutathione in protecting against severe inflammatory response, a tie-in study in 2020. How does a person get to be glutathione deficient? That's the question, right? So if we weren't glutathione deficient, like all those people under 50, like the 6% who died under 60, not like the 94% over 50 who died, how did they get deficient? What's that about? The factors that create glutathione deficiency. From that study, endogenous deficiency of glutathione as the most likely cause of serious manifestations and death in COVID. Virus infection. This is standard virus infection. So don't think of, oh, SARS-CoV-2. Think of flu season, the next virus, whatever it's going to be next year or this year, or the 3 or 4 that we're fighting, or the next variant of the one we're fighting. So you get exposure. A virus sees you. We all get exposed. And then you get the viral infection. And then you get virus replication. So your viral load is increasing. And if it increases too much, you get to a stage called advanced respiratory distress, ARDS, which means you can't breathe, which means you have to be put on a ventilator, which means you have to put on this thing called ECMO. It circulates your blood, possibly through an artificial lung. That's extreme. Otherwise, these people would have died. Another factor, so these are the factors that cause this problem. Yes, glutathione deficiency, but over age 65, low glutathione intake, lower in males, cigarette smoking, that's sort of obvious, chronic diseases, meaning they're taxing the need for glutathione, and genomic predisposition. And that's my addition that we are definitely going into. All right, the shorter answer is, details are coming up, but over age 65, endogenous glutathione progressively declines with aging due to decreased biosynthesis, kind of like the obvious, and deficient protein intake. That's where they get the sulfur. The sulfur comes in through amino acid methionine primarily, which is big about animal proteins, whether it's fish or chicken or lamb or pork or beef. That's where you get your sulfur. And as we get older, as we've talked about in other videos on protein, adults tend to eat less and less protein. So they're more and more deficient in just the beginning building blocks of glutathione. Low glutathione intake, insufficient conceptions of glutathione precursors from diet, especially during winter and spring, made even worse by vitamin D deficiency, meaning the sun. More on glutathione and vitamin D in a second. Chronic diseases. Deficiency in endogenous glutathione is a common finding in patients suffering from chronic diseases such as type 2 diabetes and obesity, cardiovascular disorders, respiratory diseases. Think of emphysema, think of bronchitis, think of COPD, cancer, liver diseases. These diseases are considered as strong risk factors for the severe course of SARS-CoV-2 or just COVID-19. Cigarette smoking, it's a chronic burden. You're using up your glutathione reserves, and when it comes time to fight something else, you're already diminished. That's sort of saying the obvious. I'm not really going to go into that. Males, the level of reduced glutathione in males and men is lower than in females. Genomic predisposition, the specific SNPs that impede the ability to create glutathione. We'll get into that. Here we go, back to what you saw before a little bit. What happens for any respiratory virus, during the flu season? So now I'm wanting you to think about flu seasons this year, next year, and for the 50 or 60 or 100 years after this, what you can do so you're not going to be one of those 94% should you be over 50, and so you're not going to be one of those 6% if you're under 50. So virus starts infecting, virus replication. There's the arts, right? We have increased virus replication, increased oxidative damage of the lungs. This middle part is what we're talking about. But our ability to control the process is very limited with right here, our immune system, if we have glutathione deficiency. It just can't fight all these reactive free radicals, reactive oxygen species. This is the heart of our immune system. Okay, the flu, infecting, virus, replication, this sore throat, dry cough, runny nose, fever, chills, headache, ARDS possibly. So this is how it looks at, and this is the heart of it, our lungs. In Chinese medicine, this is all your lungs, your nose, the back of your throat, the trachea, it's all your lungs. And you bet they have the cells which have ACE2 inhibitors, ACE2 receptors on there. The one thing you can do now is to increase your glutathione. You go, duh, yeah, of course, okay. We have the same thing, we've seen this. So now if we have glutathione deficiency, we're going to be at a loss here. If we have enough glutathione, this is exactly where we're going to be stopping the whole process, right? We're going to stop. It's not going to continue on to hyperinflammation. It's not going to continue on to organ damage, especially lungs. Okay, so glutathione deficiency is at the bottom of nearly every health crisis. You go into the hospital or anybody else, you suddenly give them glutathione, they're going to go, wow, I feel a lot better. Even has to do with post-exercise, because when you exercise, you're actually breaking things down and you're making a lot of free radicals on purpose. So your muscles will grow. But you'll find glutathione is just an amazing addition to any situation. Don't think of it as an upper. If you're deficient, it's going to make a big deal. If you're not deficient, it's not going to be a big deal. All right, back to over age 65, endogenous glutathione progressively declines because we're not making it. All right, how do we know this? All right, this comes out of, where are we? 1995, we're going to see a couple of papers on this, research on this. So this shows from 21 to 30, down here, age 21 to 30. This is both genders in this particular one, and it goes all the way over to 61 plus. So we're looking at 40 years. The decline is just numerically now. It says this is GSH concentration. We're just doing as a percentage, so we'll call that 1.1 right about here, right? And so at 1.1, when we are 20 to 30, we're 20 at 1.1. So now when we're at 60, we're at 0.5. So that's a 50%, more than a 50% reduction in glutathione by the time you're 60. So these results suggest that elderly persons are more susceptible to oxidative injury due to decreased plasma glutathione levels. You can measure glutathione intercellularly in your plasma and inside your red blood cells. And so there's different places to measure it. You got to be consistent if you're doing this in a study, of course. So 50% reduction by 60 and in 40 years. That's a dramatic change. The effect of aging on human plasma glutathione concentrations, 1995. Here we go. Here's a diagram that I stole from a similar study. This is a little more recent. Cysteine in red blood cells as a function of human age. Cysteine, that's the sulfur part of glutathione, and they're using cysteine. They're measuring cysteine, which is basically glutathione. And they're giving us a ratio of reduced glutathione versus non-oxidized glutathione. Reduced glutathione is what we need. So that's the ratio, reduced versus not reduced. Okay? And it's a very tight correlation. Here's age again. Here's from 0 to, it goes up to 90. And what do we see? We see, so I blocked out a few levels here to give you a way of looking at this, but basically we have years. By the time you are 80, all right, let's take something. By the time you are 60, it's at, we'll call that 25, and it's down about 50% by the time you're 20. And that was from Tufts. Why some people need more glutathione than others. So it's not a one size fits all. Even though I threw a lot of numbers there, and there's some studies, there was 2 studies, if not 3, saying pretty much the same thing. It's not everybody. And there's a reason this is happening. So we have decreased glutathione levels as you age. That's this brown line here. We have increased oxidative stress due to age-related glutathione deficiency. So if we don't have enough glutathione, we have more free radicals and oxidative stress. So we have this bigger battle. The battle is kind of growing on a regular basis. And when you think about it, you go, a lot of people have these aches and pains that get bigger and bigger and bigger as they get older. That's considered the norm. I don't think that's necessarily normal, or it can be far, far reduced. So oxidative stress levels blue, glutathione levels red, and the difference is the glutathione gap, what you need to fight what you have. So glutathione levels decline with age. As we age, glutathione levels naturally decrease, resulting in free radical damage and oxidative stress. This is a target for immune support. Percent decline is right here. It's 100% of glutathione. Glutathione levels decline with age. So we're looking at this distance between what you need and what you have. So obviously by the time you're 80, certainly by the time you're 60, you have a big difference. And you can see how it really jumps up, really, there you go, age 50. So it's funny how these are studies done a long time ago, how this exactly correlates with the age group from the 1918 pandemic, everything after age 50, from COVID, SARS-CoV for the last 3 years, everything after age 50, the 94% who died. Wow. So what is the glutathione gap? Glutathione levels this way, oxidative stress levels are the black. It is the difference between what you need and what you have as you get older. I couldn't put it any more simply than that. Is this real? Post from a viewer about her personal experience. Glutathione IV saved my life, first wave survivor. That was a post on just the last video that I did. It's a big deal. And if you're lucky enough to be in a place in which they have IV glutathione or IV NAC, you are going to be in a sweet situation. But the problem is 99% of us don't have access to that. If you're really sick and you're home, unless the ambulance is going to come and pick you up and take you to a place that has these things, and to have a doctor that's aware enough to say, hey, let's try this, it probably isn't going to happen. So now we're talking about the brain. Now we're going to talk about glutathione deficiency in the brain, specifically a place called the hippocampus. Hippocampus is responsible for memory, and it's responsible for learning. It's a small study, and it came out in 2022. It says hippocampal glutathione depletion with enhanced iron level in patients with mild cognitive impairment and Alzheimer's disease compared with healthy elderly participants. All right, 3 groups. Alzheimer's disease, healthy older is what they call it, healthy old, we'll call them older. And MCI, mild cognitive impairment, mild cognitive impairment. All right, these 3 gaps. Healthy, you have a high level of glutathione and a normal level of iron. Iron is an inflammatory marker when it gets to be ferritin, and it does rise with inflammatory conditions. It's like a co-marker in a way. So healthy, mild cognitive impairment, glutathione is declining, and Alzheimer's disease. Do you see the connection so far between who suffered the worst from COVID and the 1918 Spanish flu pandemic and glutathione deficiency? Do you see that? That's important. Back to these numbers. Here's the 6% of all deaths under the age of 50. It just jumps up. It's like there's this magic line of age 50 and it just jumps up. But notice relative to the percent of the population. So the percent of the population under age 50 is 42%. It's almost 50%, right? They're pretty even. So the population between really 20 and 50 is 42%. The population of the United States between 50 and 85, so that's 35 years, is 35%. Pretty equal. But yet, the lower population, the younger population between 20 and 50, only 6% died. The population from 50 to 85 was really 93, 94%. That's huge. That's the number of COVID deaths in the United States as of Pearl Harbor Day 2020. Excess total mortality rates per 10,000 persons of the 1918 pandemic. 1918 pandemic. Hit this before, but there again, it's over 50. Over 50. Over 50. Dramatic. That is the line. It wasn't like, well, it sort of got greater. No, it's the line, 50 and greater. Something collapses around age 50. So there you go. Before, if you look back into the pandemic, they go, there's this first wave and the second wave and third wave, and they all had different age groups. That's baloney. That absolutely is baloney. You look back now of 100 years and realize, no, that wasn't the case at all. And so this is each wave being looked at. Each wave had, whatever wave you're looking at, had a higher amount. The last wave was extraordinary for the older people. Okay, and that came out in 2018, so that's pretty new. So next up, as in the next video, what you're not being told about why some people have glutathione deficiency. Till then. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics, as you've seen that I've done in the past, then please let me know below in a comment. Till Until then.